Good morning everyone. My name is Dr. Vishara Trivedi and I am working as an Associate Professor of Cardiac Anesthesia at the UN Mehta Institute of Cardiology and Research Center in Ahmedabad. So in this current CC Continuous Cardiac Education program, today I have been given a topic of inotropes and vasopressors by my department. So I am going to enlighten you about this topic and we'll see one by one, step by step, how to use and which inotrope used in various conditions. So first of all, we should know what is inotropes. Okay, inotropes means basically any drug that can increase the contractility of the heart, that is known as inotropes. Other various terms which are used are chronotrope, dromotrope and lusiotrope. Chronotrope means any drug which can increase the heart rate, that is known as chronotropic. Then any drug can increase the conduction of the cardiac impulse is known as dromotropic, and any drug which can increase the diastolic relaxation of the heart is known as lusiotropic action. However, we are concerned with the inotropic action of the drugs, and so inotropy means any drug that will increase the contractility of the myocardium of the heart, that is known as inotropic. So whatever drugs we are going to see in this lecture are all inotropics, and that all are increase the contractility of the heart. There are various types of inotropes available in the pharmacy, mainly classified into catecholamines and non-catecholamines. All the catecholamines are having a beta 1 receptor action, so they all are mostly inotropes, barring one or two drugs which we will see further in the lectures. And other non-catecholamine drugs are like phosphodiesterase 3 inhibitors, like myofibril calcium sensitizers, insulin glucose infusions. All are having an inotropic action that will increase the contractility of the heart. In broad terms, these all substances have excitatory and as well as inhibitory actions on the heart and vascular smooth muscles both. So they can increase the contractility and they can dilate the vessels, that means vasodilatation, as well as important metabolic, central nervous system and presynaptic autonomic nervous system effects are also there with all the drugs. They are generally administered with the assumption that short to medium term clinical recovery will be facilitated by enhancement of cardiac output or vascular tone that has been severely compromised by often the life threatening clinical conditions. So basically all the drugs are used for short and medium term. They are not used for long term because all the drugs have tachyphylaxis and a tolerance nature. So if in a short term there is a life threatening condition, decreased cardiac output is there and you need increased cardiac contractility, then you can use all of these drugs. So first is catecholamines. Catecholamines are mainly mediate their actions through various receptors like beta 1, beta 2, alpha 1 and dopaminergic receptors. All the receptors are catecholamine receptors. So drugs which we are going to see in the next part all mediated through these receptors. The density of each receptors are very helpful, and in particular tissue is very very helpful in determining the response of the inotropes on that particular tissue. Okay, so specific cardiovascular responses are further modified by reflective autonomic changes after acute blood pressure alterations which impact the heart rate, SVR and other hemodynamic parameters. Say for example, if noradrenaline you are giving as an inotrope, the main effect of noradrenaline is on alpha 1 receptors, so it will cause vasoconstriction, and because of that vasoconstriction, despite of being an inotrope, it will have a negative effect on the heart rate. So reflex bradycardia you can see by noradrenaline. So reflective autonomic reactions are also can be seen with these inotropes. Adrenergic receptors can be desensitized and downregulated in certain conditions, like in case of chronic heart failure or chronic stress. Any kind of chronic stress will cause a repetitive surge of catecholamines in our body, and that will desensitize and downregulate the catecholamine receptors, that will limit the response of all the inotropes. The relative binding affinities of individual inotropes and vasopressors to adrenergic receptors can be altered by other factors as well, like hypoxia, acidosis. All of them cause decreased response from these inotropes. So this is the normal pathway of catecholamine synthesis. You can see here the starting of the pathway is from phenylalanine to tyrosine, then dopamine, IL-DOPA, dopamine, norepinephrine and epinephrine. So dopamine, norepinephrine and epinephrine are commercially available inotropes. So we discussed that in further part. All of these catecholamine mediated actions through beta 1, beta 2 and alpha 1, alpha 2 and dopaminergic receptors. Various receptors are present in the various parts of the tissues and mediated different actions. Like beta 1 receptors stimulation results in an enhanced contractility through calcium facilitation, actin myosin complex binding with the troponin C that will increase the contraction. However, this calcium related metabolism if you stimulate beta 2 receptor, then this will lead to calcium uptake in the cytoplasmic reticulum and that will cause relaxation. So it will lead to vasodilatation in the vessels. Alpha 1 receptors stimulation increases the contraction of the smooth muscle cells, so that will create a vasoconstriction, and alpha 2 receptors will cause increased calcium uptake from the sarcoplasmic reticulum, so that will cause vasodilatation. Dopaminergic receptors, however, present mainly in the kidney and splanchnic vasculature, and the stimulation of dopamine receptors causes the dilatation, vasodilatation in the particular tissue and causes the increase in the flow of the blood flow to the particular tissue in kidneys or in splanchnic circulations. So first inotrope we are going to discuss is dopamine. Dopamine, as you have seen in the previous chart, it is a precursor of noradrenaline in the catecholamine synthetic pathway. Now dopamine has mainly 3 dosage, and depending on the dosage requirement, the actions on the various receptor varies. On the low doses, the dopamine acts on the dopaminergic receptors, that is D1 and D2 receptors. D1 is postsynaptic receptors in kidney, renal, mesenteric and cerebral vasculature, which we have already seen that if stimulation of dopaminergic receptor will cause a vasodilatation in particular tissue and itself increase the blood supply to the particular tissue. Dopaminergic 2 receptors are presynaptic receptors present in the vasculature and renal tissues. Stimulation of that promotes vasodilatation by increasing the blood flow to the tissues, and it will have a direct natriuretic action on the renal tubule as well. If you increase the dose of dopamine, that will from 3 to 10 max per kg per minute, then it will stimulate the beta 1 receptors, and we know that beta 1 receptor stimulation will lead to inotropy. So it will increase the contraction of the heart, it will increase the heart rate, it will promote the norepinephrine release, and it will increase the reuptake of the presynaptic sympathetic nerve terminals. So it will increase the inotropy as well as chronotropy. On a further increasing the dosage of the dopamine, it will act also on the alpha 1 receptors, that is on the 10 to 20 microgram per kilogram per minute, and that will cause vasoconstriction because of the alpha 1 receptor stimulation. So if you gradually increase the dose of the dopamine, first it will act on D1, D2 receptor, then beta 1 receptors, and then lastly on a very high dose it will act on alpha 1 receptors. The next is dobutamine. Dobutamine is a synthetic catecholamine with a strong affinity for both beta 1 and beta 2 receptors, which binds to at least 3:1 ratio. So first main affinity is for beta 1, slight affinity for beta 2. However, it will not act on any dopaminergic receptors. Low doses 5 max per kg per minute, it is a potent inotropic effect by beta 1 receptors and a weak chronotropic effect. Higher dosage, from 5 to 10 max per kg per minute, it will increase the cardiac contractility, so inotropic effect without greatly affecting the peripheral resistance. Vasoconstriction progressively dominates at higher infusion rates. So at low doses, it will act through beta 1 receptors causing inotropy and chronotropy, and on a little bit high doses, it will cause beta 2 receptor stimulation, causes vasodilatation. At very high doses, it will also a vasoconstrictor. Dobutamine significantly increases the myocardial oxygen consumption because it will increase the heart rate as well as a chronotropic action. Now this exercise mimicking phenomenon is the basis upon which dobutamine may be used as a pharmacological agent for diagnostic perfusion imaging as well as in case of stress echocardiography. Side effects are mainly ventricular tachyarrhythmias because it has a chronotropic action as well, and tachyphylaxis. You can see this tachyphylaxis with almost all the inotropic actions. So we have seen earlier that it is used mainly for the short and medium term of low cardiac output syndrome or shock. Third inotrope is norepinephrine. It is released by postganglionic adrenergic nerves. Precursor of norepinephrine is dopamine. Mainly noradrenaline is alpha adrenergic actions. So it will cause mostly alpha 1 stimulation, causing vasoconstriction and causes reflex bradycardia. Because of that vasoconstriction, increase SVR. Beta adrenergic action is also present with noradrenaline, but it is in a lesser amount. So it is an ionotrope, it will increase the cardiac contractility, but because of alpha predominant action, it will actually reduces the heart rate because of the reflex bradycardia. So noradrenaline, because of alpha predominant action, is a potent constrictor, less ionotropic and chronotropic action. It will increase the systolic, diastolic and pulse pressure both. Coronary flow is also increased because of the elevated diastolic pressure. So in case of off-pump CABG, noradrenaline is a preferred choice of ionotrope because it will increase the diastolic pressure by vasoconstriction, so it will increase coronary perfusion pressure, as well as it will cause reflex bradycardia, so that myocardial oxygen demand will be less. Most important and most potent ionotrope, catecholamine ionotrope, is epinephrine, that is adrenaline, which is a high affinity for beta 1, beta 2 and alpha 1 receptors, which is present in both cardiac and smooth muscle cells of vasculature. So at low doses it is mainly beta agonistic action, and at high doses it has an alpha agonistic action. So basically at low doses it will work as an ionotrope. It will cause vasodilatation because of beta 2 receptor stimulation, but at a little bit on higher doses it will have an alpha 1 action as well, so it will increase the vasoconstriction as well. So coronary blood flow is enhanced through an increased relative duration of diastole at higher heart rates and through stimulation of myocytes to release the local vasodilators. Arterial venous pulmonary pressures are also increased through direct pulmonary vasoconstriction and increased pulmonary blood flow. So basically it will, at higher doses it will constrict all the vascular beds, so tissue perfusion may get hampered if a very high dose used for very long time. So preferably used in a low doses that will have an beta 1 agonistic action that will increase the cardiac contractility, as well as beta 2 receptor action that will cause a vasodilatation as well. Isoprenaline is a potent non-selective synthetic beta adrenergic agonist. So purely works on only beta receptors, that is beta 1, beta 2 and beta 3. So because of working on the beta 1 receptors, it will also act as an ionotrope agent and chronotropic agent. However, it is not used as an ionotrope in many of the centers, mainly used for chronotropic action. It has a potent chronotropic action that will increase the heart rate. It is a potent vasodilator because of beta 2 receptor stimulation, and it will increase the stroke volume is counterbalanced by beta 2 mediated drop in SVR, which results in a net neutral impact on cardiac output. Next is phenylephrine. Actually phenylephrine is not an ionotrope, but it is as my topic is inotropy and vasopressors, so it will work as a vasopressor. It is a pure alpha adrenergic agent which acts on the alpha 1 receptor, causes a potent vasoconstrictor, used primarily as a rapid bolus for immediate correction of sudden severe hypotension, probably due to vasodilatation. So it will counter the vasodilatation, but its action lasts for very short time, and it will also cause, because of the vasoconstriction, it will cause a reflex bradycardia as well. Baroreceptor-mediated bradycardia are also very commonly seen. Now we jump onto the non-catecholamine inotropes. The first and foremost is phosphodiesterase 3 inhibitor. The drug is milrinone. So phosphodiesterase 3 is an intracellular enzyme associated with the sarcoplasmic reticulum in cardiac myocytes and vascular smooth muscle cell that breaks down cyclic AMP into AMP. So what these agents will do is, these will inhibit the phosphodiesterase enzyme, and so in turn that will limits the breakdown of cyclic AMP, and in turn they will increase the level of cyclic AMP. Now as we have seen earlier that any drug which has a beta 1 selective agonistic action will be working as an inotropes. Now because of this beta 1 receptors, after stimulation of beta 1 receptors, this beta 1 receptor will increase the cytosolic cyclic AMP level through second messenger. So this cyclic AMP is directly increased from this phosphodiesterase 3 inhibitor without working on a beta 1 receptors. So this will also work as an ionotropic. So any drug which will increase an cyclic AMP level in the cytosol are increasing the contractility of the cardiac myocytes. Now these agents are potent inotropes and vasodilators as well, because cyclic AMP in vascular smooth muscle cells will causing a vasodilatation. So they are inotropes and vasodilators, mainly known as inodilators, and also improve the diastolic relaxation as well because of its relaxation activity because of the calcium reuptake in the sarcoplasmic reticulum. So thus it will reduce the preload, afterload and SVR as well, and in turn increases the contractility as well. So milnylone is mainly a phosphodiesterase inhibitor, most commonly used for cardiac indications. Amrino is less frequently used because of a side effect of thrombocytopenia. Another class of inotrope is myofibril calcium sensitizer. Mostly used drug is levosimendan. They also have an additional action on ATP sensitive potassium channel opening, so that will lead to vasodilatation in the peripheral vessels, so vascular smooth muscle cells relaxation, and it will increase the sensitization of the myofibril to the available calcium. So without increasing the calcium concentration, it will increase the myofibril contractility by just increasing the sensitivity. So it is also coming in the inotropic as well as vasodilatory drugs. So inodilator. This chart will give you some idea about the alpha agonist action, which will causing the vasoconstriction through the calcium, increasing the cytosolic calcium. And next vasopressor which we commonly used is vasopressin. It has no inotropic action, but it exerts its circulatory action through vasopressin receptors. It will mainly distributed into V1 and V2 receptors. V1 is subclassified into V1A, V1B receptors. V1A receptors is in the smooth muscle cells and V1B receptors in the pituitary gland. V2 receptors are mainly in the collecting duct system. So here we are concerned with cardiovascular system, so we talk about only V1A receptors. V1A receptors stimulation mediates constriction of the vascular smooth muscle cells, and whereas V2 receptors mediate water reabsorption on the renal collecting system. Vasopressin causes the less direct coronary cerebral vasoconstriction than catecholamines and has a neutral or inhibitory impact on the cardiac output. So basically, vasopressin causes a vasoconstriction that will increase the afterload, and that may hamper a failing ventricle. But in turn, if it will increase the perfusion pressure of the coronary artery by just increasing the pressure, then it may improve the contractility as well. So depending on the requirement of vasopressor, it can used. Dose dependent increase in SVR and reflex increase in the vehicle tone can be seen. Vasoconstriction through inhibition of the ATP activated potassium channel, attenuation of nitric oxide production, and reversal of adrenergic receptor downregulation. All of these are action on the vasopressin. So pressure effects of vasopressin are relatively preserved during any kind of hypoxia, acidosis or any other drug which can lead to desensitization of the catecholamine receptors. So in case of refractory shock from adrenaline or dobutamine or noradrenaline or any catecholamine, you can use vasopressin as an agent of choice. So this table will give you some of the idea about which inotrope is working on which receptors and what are the clinical indications. You can see here the noradrenaline, the clinical dose is 0.01 to 3 max per kg per minute. Clinical indication is distributive shock. That means any shock which is associated with severe vasodilatation. Side effects of noradrenaline is arrhythmias and peripheral ischemia because of severe vasoconstriction. Vasopressin, again same distributive shock with increased heart rate, and which is not desired. Okay, again the side effects is peripheral ischemia and splanchnic constriction. Epinephrine side effects is arrhythmias and peripheral ischemias. Drug of choice in anaphylactic shock and refractory shock. Phenylephrine mainly because of used in vasodilatation, severe vasodilatation. Reflex bradycardia is the side effects. Dobutamine used mainly in cardiogenic shock, low cardiac contractility, high SVR in cardiogenic shock. So you can use dobutamine. Mainly used in post-operative cases. Side effects is tachyarrhythmias and cardiac ischemias because of increased chronotropic action. Isoprenaline not used mostly as a inotropic agent, used as a chronotropic agent in bradyarrhythmias. However, the side effects are tachyarrhythmias and cardiac ischemias. Dopamine, as we have all discussed, total 3 doses. Depending on the dose, it will act on the various receptors. Can be used in all types of shock as a starting agent of choice, inotrope, and then it can lead to tachyarrhythmias and cardiac ischemia as well. Again, another drugs, milnylone, amrinone, vasopressin, levosimendan, we have discussed all of this. Side effects of milrinone is ventricular arrhythmias, hypotension, thrombocytopenias, and maybe sometime torsades diapontis. Vasopressin we have seen. Levosimendan side effects is tachycardia and enhanced AV conduction. Hypotension can be seen sometimes in levosimendan because of severe vasodilatation. So after discussing all the agents, we just look at the total mainly 3 indications where you can use inotropes as a drug of choice. The first and foremost is cardiogenic shock. Because of low cardiac contractility, tissue perfusion is hampered, and so it is known as cardiogenic shock. In this case, inotropic agents are drug of choice. It will improve the mitochondrial functions as well as in non-infarcted myocardium that has become deranged during an acute MI shock. These agents are increased myocardial oxygen consumption and can cause ventricular arrhythmias as well, contraction band necrosis and infarct expansion. They can also increase the myocardial oxygen demand by increasing in chronotropy as well. Lowest possible doses of inotrope and tracer agents should be used to adequately support the vital tissue perfusion, because all the inotropes on very high dose, they all are causing a severe vasoconstriction and hampering the tissue perfusion. So low and effective dose should be used. Vasopressin therapy is effective in norepinephrine resistant shock. It should be a reserve drug, improving MAP, cardiac index, Lalbe-Stoke work index, and reducing the need for norepinephrine, resulting in decreased cardiotoxicity and malignant arrhythmias. Vasopressin may also attenuate the interleukin-induced generation of nitric oxide and have a modest inotropic action on the myocardium via V1A mediated increase in cytosolic calcium. It can improve the coronary blood flow due to catecholamine sparing effect as well. So in case of refractory cardiogenic shock, you can use vasopressin. Second important indication for all the inotropes are heart failure. So inotropic therapy is used in the management of decompensated heart failure to lower end diastolic pressure and improve diuresis. Current American College of Cardiology, American Heart Association guidelines for diagnosis and management of heart failure in the adult do not recommend the routine use of intravenous inotropic agents. They don't allow intravenous use of all the agents because all of these agents should be given intravenously. So as we have discussed, it is used mainly for short and long term. So to prevent the intermittent crisis of failure, you can use intravenous inotropes, but not routinely recommended in the first choice. So all the inotropes will improve cardiac output and enhance diuresis, improve the renal blood flow and decreasing the SVR. Milrinone causes relatively more significant right ventricular afterload reduction through pulmonary vasodilation and less direct cardiac inotropy, which results in less myocardial oxygen consumption, so mainly used for right ventricular dysfunction. And as we can see that levosimendan is mainly a peripheral vascular vasodilatation, so it will reduces the SVR more and increase the contractility, so it is mainly used for left ventricular dysfunction. Post-operative cardiac surgery, mainly used inotropes in this subset of patients after weaning from cardiopulmonary bypass in patients who have developed a low cardiac output syndrome. No single agent is universally superior in this setting. Dobutamine has the most desirable side effect profile of beta agonist. Phosphodiesterase inhibitor increases the flow through arterial valves, reduces the MAP and improves the right-sided heart failure. Levosimendan will improve the left-sided heart failure. Vasoplasia syndrome can be seen after coming off bypass because of severe inflammatory reactions that will lead to severe persistent hypotension, acidosis, decreased SVR and low pressures. You can use vasopressin in subset of patient in the case of refractory vasoplasia. Catecholamine therapy mainly ineffective in such refractory vasoplasia. You can use vasopressin, and if refractory to vasopressin as well, you can use a methylene blue also. So in short, if we want to summarize that which inotrope should be used, the first you should know whether the inotrope is required or not. If the required, then you should know whether the inotrope is required with vasodilatation or with vasoconstriction to maintaining the perfusion pressure. So if the inotrope is required with vasodilatation, the drug of choice is dobutamine. If the inotrope is required with vasoconstriction, then adrenaline is a drug of choice. However, in case of severe vasodilatation, you can use a vasopressors like norepinephrine, vasopressin, or in sometimes to prevent the crisis, you can use phenylephrine as well. and in case of diastolic dysfunction, that means you need a lusiotropic action, the drug of choice would be a milrinone or levosimendan. Thank you.